I'm here today to talk about cannabis in cancer care, and I do have a few disclosures to make. I am a scientific advisor to a number of the burgeoning cannabis industry worldwide. And what I'd like to do today is to review the results of trials that investigating cannabinoids in the treatment of some cancer-related issues, to describe the potential utility of cannabis, particularly in peripheral neuropathy, to summarize data regarding cannabis and the risk of cancer, and to outline possible ways that cannabinoids may have direct anti-cancer effect, which I know is certainly of interest to many, especially after seeing the film last night. So this is the remains of the Siberian ice princess, who was discovered in Siberia, a very well-preserved mummy. In fact, her tattoos are being copied by millennials, I understand. Under an MRI, she appears to be a 20-something-year-old woman who had metastatic breast cancer. And around her waist, she had a belt, and at the end of the belt was a pouch in which were the flowers of the plant of Cannabis sativa. So this led the archaeologists or anthropologists or whoever makes these decisions to decide that perhaps the ice princess was using cannabis to ease the symptoms of her breast cancer or perhaps even to treat the cancer itself. Personally, I think that is a very big leap because we don't know that everybody in her tribe was not buried with a pouch of cannabis around their waist, but so be it. I'm an oncologist in San Francisco. I've been an oncologist for 36 years. Let me just give you a little bit more how I got into this field. At the beginning of my training to be an oncologist, suddenly AIDS came out of the blue and we didn't know what it was or what to do about it. So I became a champion of alternative therapies even when there was no conventional therapy to be alternative to. And then when we got conventional therapy, some of you may remember something called AZT, I said, oh, this isn't very good. So I wrote all the chapters in all the AIDS textbooks on complementary and alternative therapies in HIV. And then in 1992, somebody challenged me to study cannabis as a treatment for the AIDS wasting syndrome. And I said, okay, I can do that. I went to college in the 60s. So I fought the government and ultimately won and got cannabis and money, $1 million, to do research, which gave me a strong appreciation of the power of plants as medicine, which ultimately took me to the Mushroom Festival in Telluride, Colorado, a month after I'd done my first ever jury duty and came home and said, I want to go to law school. But in Telluride, I met Andrew Weil, the guru of integrative medicine, who described a 2-year online distance learning fellowship you could do with his training program at the University of Arizona in integrative medicine. And I said, I don't want to go to law school, I want to do that. So I did, and it changed my life. When I finished, I said, I'm done with HIV/AIDS. I've done that for 25 years. It's very different from what I started. What I want to do now is integrative oncology, working with people living with and beyond cancer and helping them to integrate nutrition, physical activity, supplements, including cannabis, Chinese medicine, mind, body, spirituality, into their conventional care. So I am a Gemini. So at Zuckerberg San Francisco General Hospital, I treat cancer. And at our Osher Center for Integrative Medicine, I treat people living with cancer because I'm not treating their malignancy. I tell them cancer is like a weed, and someone else is taking care of your weed, and it's my job to work with the garden and make your soil as inhospitable as possible to growth and spread of the weed. And in both situations, I'm often recommending that my patients turn to cannabis. And if we look at the symptoms that our patients deal with, weight loss, cachexia, early satiety, anorexia, pain, anxiety, depression, nausea, and vomiting, we have one therapeutic that we could recommend. I stopped from saying medicine because we'll get into that later. I want to call it a botanical therapy that we can recommend to patients, and that is, of course, cannabis. So what do we know about cannabinoids and appetite? Anandamide, the endocannabinoid, in low concentrations in mice leads to potent enhancement of appetite. And we know that the CB1 receptors are implicated in food intake control, probably through the limbic system. If you take mice and genetically program them so that they do not have a CB1 receptor, they eat less than wild-type litter mice. The endocannabinoids seem to enhance the reward effects, and interestingly, as we saw in the movie last night, mother's milk is a very rich source of 2-AG, the other endocannabinoid. So pharmaceutical companies notice that if you give mice shortly after birth a CB1 receptor antagonist, that they stop suckling and die. And this led a number of pharmaceutical companies to try to develop CB1 antagonists as a method for people to lose weight who are overweight. Manuel Guzman, my friend and colleague who studies the anti-cancer effects of cannabis in Madrid, at a meeting in Europe, I asked him how anandamide, the drug, the name I'm forgetting at the moment, was doing, because it was licensed and approved for treatment of overweight in Europe. And he said, "Donald, would you block your CB1 receptor?" And in fact, when you look at what happens to mice when you block their CB1 receptor, you do in fact suppress feeding and get some weight loss, but you also increase anxiety and you reduce the ability to experience pleasure. And so these mice develop symptoms that are very consistent with melancholic depression. And Acomplia, or rimonabant, that's the name of the pill, which was licensed and approved throughout the European Union, ultimately was removed from the market, was never approved in the United States by our FDA because they were concerned about the depression. And in fact, it was not only depression that patients suffered using Acomplia for weight loss, but it was also suicide, which is definitely a high price to pay to lose weight. So what do we know about the effects of cannabis on food intake? Now, the study was done by Fulton, who developed the famous Fulton puff procedure. And he did this study back in 1988. He put 2 groups of 3 adult men in a residential facility for 13 days. And for the first part of the day, they were confined to their room, and the second part of the day, they were allowed to socialize. And they smoked 2 cigarettes containing what we would consider today very low dose THC, 2.3%, or placebo during both the private and the social periods of the day. And what they found was that smoked cannabis increased caloric intake by 40% during both the private period and the social period. And the increase was in snack calories, not at mealtime. And sweet solid items, not sweet liquids or savory solids, were preferred, i.e. otherwise known as the munchies. But what do we know about cannabinoids and appetite in patients with cancer? So one of the things that we need to make very clear here is that in our country, and I think it's probably the same here, cannabis is a Schedule I substance, which means it has a high potential for abuse and no accepted medical use. And the only legal source of cannabis for doing research is our National Institute on Drug Abuse, NIDA. And NIDA has a mandate from Congress that they can only study substances of abuse as substances of abuse. So if you want to study the potential health benefits of cannabis, you must use NIDA cannabis, but they cannot fund such research. They can only fund research looking at the potential harm. So this led to the development of delta-9 tetrahydrocannabinol as a drug, dronabinol, licensed and approved for treatment of chemotherapy-induced nausea and vomiting back in 1986. So this is a study where dronabinol was compared to the progestational agent megestrol, or the combination of the two. And you can see that dronabinol was inferior to megestrol in increasing both appetite and weight. And when you combine them, dronabinol seemed to decrease some of the potency of the megestrol. A smaller randomized controlled study of dronabinol in cancer patients demonstrated that it did increase the chemosensory perception of the food, that it looked better, smelled better, tasted better, and they ate more calories, but they did not gain any weight. Now, one of the big questions that I'm faced with all the time as our dispensaries have gotten way ahead of our science, in California, by the way, where I practice, we have had medical cannabis legal since 1996. So we have a very sophisticated dispensary system, and they have many, many sorts of products. And CBD, or cannabidiol, as you all know, has become catapulted to the top of the most favored cannabinoid because I think because it doesn't produce euphoria. And we are all Puritan-derived, living in a Judeo-Christian culture where euphoria is frowned upon. I don't think there's anything wrong with euphoria personally, but CBD has come to the top because it's supposedly not psychoactive, which is also incorrect. But in a study trying to determine is CBD good for appetite stimulation, which I don't see actually how it could be because CBD, unlike THC, does not complex with the CB1 receptor in the brain. This study demonstrated that, in fact, the patients receiving the lower THC on the bottom, 6%, with 7.5% CBD, did report less anxiety and a sense of dejection, but also less appetite stimulation. So it would seem to me to be THC, which is the component for increasing appetite. Now, the most recent study, just reported last year, was a study of the other delta-9 THC product, nabilone. This was a randomized placebo-controlled trial in 47 outpatients with non-small cell lung cancer that was conducted in Mexico. And again, at 8 weeks, the nabilone patients had increased caloric intake compared to the placebo group and a higher intake of carbohydrates. And the investigators report significant quality of life improvement. However, they don't report any difference in weight. So again, the report of the National Academies of Sciences, Engineering, and Medicine, which I was one of the committee members of, which I'll be discussing tomorrow, actually concluded that there was not very good evidence or no or insufficient evidence that cannabinoids increase weight in people with cancer. And the committee, which had to review our findings every day because different people worked on different things, were all very surprised when we announced one afternoon in Washington that cannabinoids don't increase weight. Everybody said, what? Because everybody had experienced the munchies and knew that cannabis increases appetite. So, however, if you look at people who are chronic cannabis users, they are less prone to develop metabolic syndrome and diabetes and less frequently obese than people who don't use cannabis. So this whole question of appetite and weight is, again, unclear because really we don't have any evidence from the use of cannabis itself. So dronabinol actually was, the indication for it was expanded in 1992 for the treatment of anorexia associated with weight loss in patients with AIDS. Well, why would the Food and Drug Administration expand the indication for dronabinol from chemotherapy-induced nausea and vomiting to treatment of anorexia? In the placebo-controlled trial, dronabinol did not increase weight, it only increased appetite. Up until 1992, the US government was providing a handful of patients, less than 10, with 300 cannabis cigarettes a month for so-called orphan diseases that they felt might be helped by the use of cannabis, even though it's Schedule I and has no accepted medical use. In 1992, we had a big problem with the so-called AIDS wasting syndrome. AIDS patients, before we had effective antiviral drugs, wasted away with weight loss, fever, and diarrhea. And the government got concerned that these patients, who numbered in the thousands or tens of thousands, were going to say, hey, we have an orphan drug, and we want 300 cannabis cigarettes a month as well. So Bush 1 closed the so-called compassionate use program, and at the same time, the Food and Drug Administration expanded the indication for dronabinol to include treatment of the AIDS wasting syndrome. So what about nausea and vomiting? I think the interest in the 1970s was prompted by anecdotal reports from young patients with cancers that young patients get, i.e. Hodgkin's disease and testicular cancer, that we still treat today with essentially the same chemotherapy that we used in the 1970s, telling us that our available antiemetics at that time, predominantly prochlorperazine, were not so effective or not as effective as smoking cannabis. So the National Cancer Institute and a number of pharmaceutical companies began to develop oral THC as an antiemetic. and it appeared to be better than placebo and equivalent to the currently available antiemetics. And in fact, anecdotally, smoked THC appeared superior to the oral. If we lined it up today, THC would not be the most potent antiemetic that we have in cancer patients, but it does help many people. Again, 30 randomized trials of nabilone, dronabinol, or an intramuscular THC were available to be meta-analyzed, and all of these studies demonstrate that cannabinoids are more effective than phenothiazines and metoclopramide. And again, these studies have been subjected to numerous meta-analyses and systematic reviews as if something's going to change. They're all the same studies that are being re-reviewed from the 70s and 80s. One of the concerns about dronabinol is that there isn't any comparison to a modern antiemetic. So this is a study in delayed nausea and vomiting where dexamethasone or ondansetron, the serotonin inhibitor, and or dronabinol or placebo were prescribed for delayed nausea and vomiting in 61 patients that received highly emetogenic chemotherapy. And the total response was the same for ondansetron, which is the standard of care, and dronabinol, or the combination, which were all better than placebo. And it was reported that nausea intensity and vomiting retching were actually less in the dronabinol recipients. So again, this is the health effects of cannabis and cannabinoids, the current state of evidence and recommendation for research from the National Academies of Science, Engineering, and Medicine in the US. This was a 500-page volume that was published in January of 2017 at the request of a number of US agencies that I will discuss in further detail tomorrow. And the conclusions in the therapeutic session clearly state that in adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective antiemetics. Again, where's the data on cannabis? There are only 3 randomized clinical trials of cannabis as an anti-nausea agent in patients with chemotherapy, and in 2, cannabis was only available after dronabinol had failed, so really a setup for failure. The third was a randomized double-blind placebo-controlled crossover trial in a small number of cancer patients, and again, I find that data a little bit difficult to interpret myself. Now, nabiximols, which I believe is available here, it's the 1-to-1 THC CBD whole plant extract delivered as an oral mucosal spray, was studied again in a small number of patients with receiving chemotherapy in addition to their antiemetics. And 5 sprays a day of nabiximol was more effective in decreasing nausea and vomiting than placebo. But this is just one email from a patient, a 48-year-old gentleman with metastatic colon cancer wanting an extension of the medical cannabis letter that I issued. Although I did not use it until my last 5 sessions of chemo, me getting over the stigma of its use, it did what no other drug could do, completely solve the severe nausea I had. It allowed me to play with my children, attend their sports and school functions, and just function very normally in day-to-day activities. I cannot thank you enough for giving me that option. I'm currently on a chemo vacation after a clean scan, and the only time I use medical marijuana now is when I have trouble sleeping. I would like to continue to use it for that purpose instead of relying on pharmaceutical options. And again, I believe it was Melissa Etheridge who said that she could not have tolerated her adjuvant chemotherapy for her breast cancer without using cannabis. And last night we heard that Olivia Newton-John also had a good experience. Unfortunately, the American Society of Clinical Oncology, which is similar to Australia's COSA, expert panel recommends FDA-approved cannabinoids, dronabinol or nabilone, to treat nausea and vomiting that is resistant to standard antiemetic therapies. Evidence remains insufficient to recommend marijuana in this setting. And I find this to be too conservative and short-sighted, but of course these are oncologists, and that's what we are sometimes. What about cannabinoid acids? So THCA and CBDA, again, also popular because they're not psychoactive. They do suppress nausea and vomiting in animal models, and THCA lacks CB1 receptor activity, hence doesn't produce psychoactive effects. In animals, THCA was at least 10 times more potent than THC in acute and anticipatory nausea, and CBDA is 1,000 to 5,000 times more potent than CBD. Now, I don't know if that means CBD is not effective at all. These acids, in my understanding, have not yet been studied for this indication, but it is a reason that people are increasingly talking about juicing cannabis, because that's how you derive these acids. So I think in a paper from Bar Schliedler that was published, she looked at 2,000 participants in the Israeli cannabis experience, and if you look at the most improved symptoms, you see nausea and vomiting 91%, followed by sleep disorders, restlessness, anxiety, depression. And then with regards to the next speaker's presentation, 1,000 of the patients reported changes in their medications, and of 344 on opioids at onset, 36% actually stopped their opiates and 10% decreased the dose. So another reason that I found myself recommending cannabis to patients was shown on this slide. First, let me just say that I think since January 2018, California has had recreational cannabis, so I don't need to write any letters anymore. We could never prescribe cannabis in the United States because it's federally still illegal, and the only way you can prescribe it is if you have a Schedule I license to do research like I do. We could only recommend cannabis. But as of January 1st, 2018, everybody can access cannabis without a physician's letter. The only benefit of the letter is sometimes you pay less tax at the dispensary. But this shows you the linear relationship between alcohol intake and the development of postmenopausal estrogen receptor breast cancer in women. So at the Osher Center, I care for a number of women who are survivors of estrogen receptor positive breast cancer, and they're back at work. And their work colleagues want to go out for a drink, or they come home from work and their husband comes home from work and he said, let's have a cocktail. And my patients say they would prefer to be socially lubricated without alcohol because of the known risk of alcohol. And not only breast cancer, but 5% of all cancer in the United States is now related to alcohol. And since I believe that cannabis is infinitely safer than alcohol, I happily wrote these patients' recommendations. But what about smoking a medicine? Is that healthy? Well, tobacco still accounts for 28.6% of avoidable cancers in the United States today. What about inhalation of cannabis? Does cannabis cause cancer? The U.S. National Toxicology Program conducted a 2-year study in rodents where mice and rats received increasing dosages of THC via a tube in their nose into their stomach. And what they found was that there was a dose-related decrease of both benign and malignant tumors, and that the animals receiving THC actually lived longer. This research was actually suppressed for about 3 or 4 years after it was done, until somebody sent me a draft of it, and I said, what's going on? And they rapidly published it. Kaiser is one of our large health maintenance organizations, and Steve Sidney, who's a medical school classmate of mine, did this analysis a number of years ago, looking at 4 groups of Kaiser patients, all men aged 15 to 49, followed for 10 years. So each group had 10,000 men, so it's a huge patient years of follow-up. In people who never smoked cannabis or tobacco, there were 2 cases of lung cancer diagnosed. In those who smoked tobacco alone or tobacco plus cannabis, the risk increased 10-fold over never smokers, which is the risk of smoking tobacco. In those who only smoked cannabis, there were no cases of lung cancer documented. And because that's such a large N, this was statistically significant. Now, you can't read this at all, but this is the work of Donald Tashkin, who's a friend and colleague at the University of California, Los Angeles, who's been funded for 40 years by NIDA to look at the harmful pulmonary effects of cannabis. And this was his pièce de résistance, a study of 1,350 people in the Los Angeles basin with upper aerodigestive malignancies. And he compared 1,356 people with lung, esophageal, and gastric and head and neck cancers to an equal number of people who didn't have cancer. And he found that people who low dose used cannabis had actually a 37% reduction in their risk of lung cancer compared to people who didn't smoke at all. So what about the medical literature? There are 6 population or clinic-based case-controlled studies, including 2,195 cases and 2,985 controls. And the conclusion from an article in 2015 was that there's little or no association between cannabis use and lung cancer incidence. The only study which seems to question that is the so-called Swedish conscript studies, where men in Sweden being inducted into the army at age 18 were asked if they ever used cannabis. And then 50 years later, they were evaluated for lung cancer without being asked if they still use cannabis and whether or not they smoked tobacco. And so that study did show an increased risk, but it's felt to be poorly done because of not controlling for tobacco. So in our chapter on cancer at the National Academy of Sciences, we concluded that there is moderate evidence of no statistical association between cannabis smoking and the incidence of lung cancer, which actually was a surprise and somewhat distressing to one of our funders. We also concluded that there's moderate evidence of no statistical association between cannabis use and the incidence of head and neck cancers. We did say that there's limited evidence of a statistical association between current, frequent, or chronic cannabis use and non-seminomatous germ cell tumors or testicular cancer from the literature. Now, we had somebody come from the National Driving and Transportation Association who came to talk to us about whether or not there was increased traffic accidents in the states where cannabis was approved. And he said that if you adjust for one factor, the increase disappears. He said, who smokes cannabis? Young men. Who gets into traffic accidents? Young men. So if you do that adjustment, the increase disappears. Similarly, who smokes cannabis? Young men. Who gets non-seminomatous germ cell tumors? Young men. So this is a statistical association, but it's not necessarily proof of causation. It's similar to the finding that there are increased drowning deaths in months where ice cream is overconsumed. True, and unrelated. Now, as oncologists, we're very concerned about patients using botanicals because of the possible interference with chemotherapy. Unfortunately, there is very little data on this in the medical literature. There's no adverse effect of a cannabis tea with 2 chemotherapeutic agents, but I don't know many patients who actually use cannabis as a tea. Cannabinoids with chemotherapy in mice seems to act synergistically with regards to decreasing brain cell tumor viability, and also cannabinoids with gemcitabine decrease the viability of pancreatic cancer cells. Now, Barcella in Israel did an interesting retrospective review of patients with lung cancer and melanoma receiving the new immunotherapy, nivolumab, a PD-L1 inhibitor. And this was not a randomized prospective study, but what they found in this retrospective review was that the patients who used cannabis with nivolumab had actually a decreased response rate compared to patients who did not receive or use cannabis with their immunotherapy. However, the survival was the same. So I've tended to, despite the fact that this is retrospective and not the most potent evidence, I sometimes caution my patients on immunotherapies that it might be best not to use cannabis during that potentially very effective treatment. The other thing that oncologists really worry about a lot is the deep fungal infection caused by aspergillus. I think that there were a number of case reports. The first one by Tony Fauci, who's currently the director of our National Institute of Allergy and Infectious Disease. From when he was a fellow in 1975, they saw a young man with pulmonary aspergillosis and felt it was from his use of cannabis. Subsequently, there are isolated case reports in patients with hematologic and solid malignancies and other immunocompromised states. They are mainly from smoked cannabis, although in 2015, there was a patient who reportedly got aspergillus and only vaporized cannabis, which to me seems impossible. Impossible. In 13 AIDS-related cases, cannabis was suspected in 4. However, I think the best study is a case control study of 19 HIV patients who had positive aspergillus in their bronchoalveolar lavage. And in this study, they found that the presence of aspergillosis was associated with a lower white blood cell count, a neutrophil count, lymphocyte, CD4 count, use of steroids, and prior pneumocystis, and cannabis use was not associated. So how about cannabis as an anti-cancer agent? We heard about that quite a bit in the movie last night. In 1975, NIH investigators at our National Cancer Institute reported that delta-9 THC, delta-8 THC, and cannabidiol all inhibited Lewis lung adenocarcinoma cell growth in vitro and in mice. An increasing body of preclinical evidence has been developed. Much of this research has moved off the coast of the United States to Europe, in Spain and Italy, where an increasing body of evidence suggests that cannabinoids may have anti-cancer activity. Cannabis, as we know, is also an antioxidant and anti-inflammatory, and those are 2 factors that I look for in botanicals that I recommend to my patients. And there's a possibility of anti-tumor activity by way of the CB1 receptor. Multiple tumor cell lines are inhibited in vitro. And if you take nude mice that don't have an immune system and transplant them with all of those human tumor types, they can be inhibited with cannabinoids. Now, most of the work in this field comes from the laboratory of Manuel Guzman at Complutense University in Madrid. Manuel's laboratory studied the effect of cannabinoids on metabolism, and the most metabolically active cells in the body are the brain. So they grew up rat brain cells in culture and added cannabinoids and saw what happened. And they said, well, maybe we can do our work faster if we use brain tumor. So they grew up a rat glioma and they added the cannabinoids and everything died. And they said, oh, we must have done something wrong, so they did it again and everything died. So they said, maybe this was a bad batch of cannabinoids. They went back to the normal rat brain and everything lived. So subsequently, they have done an incredible amount of work looking at the mechanism of action of cannabinoids in vitro in these cell culture models. Cannabinoids induce programmed cell death, or apoptosis. And in addition, cannabinoids also reduce the expression of vascular endothelial growth factor, which allows blood vessels to grow and feed the tumor. And in addition, cannabinoids decrease the activity of an enzyme called matrix metalloproteinase 2, which allows cancer cells to become invasive and metastasize. So that's all very exciting and very elegant, but in our review for the National Academies of Science, Engineering, and Medicine, we were only supposed to include human studies. And there is a paucity of human studies of cannabis in cancer in the medical literature. So there's one meta-analysis from 2014 that included 34 in vitro and/or in vivo experimental studies and 1 pilot human trial. And all but 1 study showed that cannabinoids selectively kill tumor cells. And again, these are gliomas. Now, what's the most densely populated 7-transmembrane domain G protein coupled receptor in the human brain? The CB1 receptor. So it makes sense that if cannabis is going to have any activity against any malignancy, it's going to be brain tumors, in my opinion. So the anti-tumor activity was multifactorial, as I mentioned. Now, the first human trial was done by Manuel Guzman, who went to the Canary Islands, found 9 patients with recurrent glioblastoma and treated them with THC dripped by way of a catheter into their tumors. I told him, Manuel, we don't treat brain tumors topically. Well, he said the treatment was well tolerated, but there was no effect on survival that was different from the group that got chemotherapy alone. In vitro, however, when he took pieces of the brain tumors, THC inhibited the proliferation and decreased the viability of the glioblastoma cells from the biopsies. And it was later demonstrated that if you added CBD, it enhanced those beneficial effects of the THC. Now, Rottenberg in Hadassah Medical in Israel had reported that he was doing a study of pure CBD as a single agent for solid tumors in clinicaltrials.gov. And for a talk a number of years ago, I sent him an email and asked him what the status of that 60-patient study was. He told me that he closed it after enrolling 3 patients with glioblastoma and 1 with, I believe it was pancreatic cancer, having seen no response because it was difficult to accrue patients. Now, the one study that we're waiting to be published with some enthusiasm is a very small study, again, 21 patients with recurrent glioblastoma multiforme, the most aggressive brain tumor, treated with chemotherapy, but in addition, they got sprays of the 1-to-1 CBD THC nabiximols versus placebo. At 1 year, there was a statistically significant survival benefit for the patients receiving nabiximol, 83% compared to 53%. And the median survival at the time that this was reported as a press release in February of 2017, that's over 2 years ago, was 550 days for the nabiximols group compared to 369 for placebo. I'm told that they're waiting for that difference to plateau before the actual paper is published. But I look forward to seeing the results of this study sometime in the near future. So, you know, I've been an oncologist in San Francisco for 36 years. I would venture to say that the majority of patients I've cared for in my practices have used cannabis. And if cannabis cured cancer, I would have a lot more survivors. Okay, so that's maybe inhaled cannabis, not these potent oils of high percent THC and CBD. Perhaps it's selection bias, but I don't see patients benefiting from those interventions. In fact, the saddest thing for me is when I see a patient who's waited 6 months to see me in my clinic, treating a potentially curable malignancy with cannabis instead of standard conventional therapy, who now has metastatic disease and can't be cured. CBD is a potent inhibitor of the enzyme system in the liver that metabolizes other drugs. People taking highly concentrated CBD put themselves at risk for increased toxicity from pharmaceutical agents. So I think we don't really know enough about this to make claims about cannabis and cancer. I think this is very exciting that there is differential expression of CB1 and CB2 receptors in a number of different tumor cell types. Unfortunately, sometimes that's associated with a poor prognosis, and sometimes it's associated with a good prognosis. So most of that is about THC. What about CBD? So in colorectal cancer cell lines, CBD seems to reduce cellular proliferation. And if you treat mice with a chemical that leads to the development of adenocarcinomas, this is decreased if they're pretreated with CBD. At non-cytotoxic concentrations, CBD is also anti-proliferative against colorectal cancer cell lines. A colleague, Sean McAllister in San Francisco, noted that triple-negative breast cancer, which is the most aggressive breast cancer, expresses increased levels of something called ID helix loop helix proteins in the test tube. These proteins control processes related to tumor progression. When he added CBD in the test tube, it downregulated ID1 expression in aggressive human breast cancer cells in vitro. This led to the San Francisco Chronicle to put out a headline that marijuana cured breast cancer. And I saw a number of women coming to see me to ask if they should use CBD for their triple-negative breast cancer. I said, you know what? I was an AIDS doctor for many years. Soap suds and gasoline kill the virus in the test tube, but I wouldn't necessarily recommend either of those as treatments for the disease. Similarly, I think there's a huge leap here, but people make that leap, and this is what our patients can see on the internet: cure your own cancer with CBD. I find that to be irresponsible and criminal. I don't know. I'm one of the authors of the National Cancer Institute Physician Data Query webpage, NCI PDQ Cannabis, and you will get an update both for physicians and patients on the current state of the literature on cannabis and cannabinoids for symptom management as well as for potential anti-cancer effects. So in conclusion, even our most conservative New England Journal of Medicine ran a piece on Marilyn, a 60-year-old woman with metastatic breast cancer, seeking cannabis to alleviate her symptoms. Again, this was about 6 years ago. And the two discussants, pro and con, unfortunately were both mental health practitioners and not oncologists. But they opened this up to a blog afterwards, and they received 1,446 votes from 72 countries, and they remarked that they were surprised by the outcome of polling. And comments with 76% of all votes in favor of the use of marijuana for medical purposes, even though marijuana is illegal in most countries. And that was followed by a WebMD survey, again, also 5 years ago, where they surveyed 1,500 physicians from 12 specialties in 48 states in the United States. 2/3 felt that cannabis was a useful medicine, and I'm proud and pleased to say that oncologists showed the highest percentage of support with 82%, and only the lowest was rheumatologists, 52%. Now, I am often placed on the radio against an addiction medicine specialist to discuss cannabis, and I say, you know, that's really not fair. It's sort of like the blind men and the elephant, because we see totally different parts of the animal. An addiction medicine specialist is a little bit like an orthopedic surgeon at the bottom of a ski slope. They only see the disasters, whereas oncologists see all the benefit of this medication. And even pediatric oncology, this was a survey of 654 pediatric oncology providers in Illinois, Massachusetts, and Washington. 92% said that they would help pediatric patients access cannabis, felt it was appropriate at all stages of disease. Unfortunately, Ilana Braun published in the Journal of Clinical Oncology, the organ of oncologists in the United States, the journal we all read, a survey of 400 random oncologists. 80% said that they conducted discussions regarding medical cannabis with their patients. 78% that the discussions were patient-initiated. 67% viewed cannabis as a helpful adjunct. 65% thought it was equally or more effective than the standard therapy for anorexia and cachexia. 46% recommend it. 30% felt sufficiently informed to make the recommendations. I've recently written a larger article, Should Oncologists Recommend Cannabis? And my conclusion is that cannabis does not require a package insert. I don't think we need physicians necessarily to tell patients how to use it. I think they can figure it out for themselves. So my recommendation is to study this more. And when my colleagues in oncology ask me, Donald, why in these days of nanotechnology, immunotherapy, and genetic reprogramming are you continue to study a plant? And I say it's to return us to the roots of medicine. And with that, I'll stop and thank you for your attention.